After greeting and introducing yourself to the patient, identify the patient by asking his or her complete name, gender, and birthday. Also, don't forget to ask permission to the patient and explain the procedure. Before you begin, you must observe proper hand hygiene. Make sure that your nails are short to avoid scratching or scraping the patient's skin, and perform proper hand washing for a minimum of 20 seconds. First, let the patient lie supine and relaxed. Slide your hands under the lower back to see if the patient is relaxed and lying flat on the table. Ask the patient to keep the arms at the sides or folded across the chest. Next is draping the patient. To expose the abdomen, raise the shirt below the nipple line just above the xiphoid process and place a drape sheet at the level of the symphysis pubis. The groin should be visible but the genitalia should remain covered. First is inspection. Try to check if the patient is in pain or discomfort. Observe the general appearance of the abdomen. Inspect the surface for lesions, scars, or striae. Observe the contour. Is it flat, round, protuberant, or scaphoid? Is it symmetric, or are there any visible organs or masses? Also check for any movements of the abdomen by viewing it tangentially, noting for peristalsis or pulsations.
Next is auscultation. This provides important information about bowel motility. Using the diaphragm of the stethoscope, place it gently on the abdomen and note the frequency and character of the bowel sounds. Because the bowel sounds are widely transmitted through the abdomen, listening in one spot such as the right lower quadrant is usually sufficient. Normal sounds consist of clicks and gurgle, with an estimated frequency of 5 to 34 clicks per minute.
Altered bowel sounds are suggestive of peritoneal inflammation or obstruction, and bruits, which are vascular sounds similar to heart murmurs heard over the aorta or other arteries in the abdomen. Auscultate for bruits over the aorta, iliac arteries, and femoral arteries. Next is percussion.
This is usually performed by placing only the finger's middle phalanx or the pleximeter of the non-dominant hand to the area. Striking the pleximeter with the tips of the middle and index finger of the dominant hand or the plexor in a quick wrist motion. Make sure that the pleximeter and the plexor are parallel and not perpendicular to each other. Percuss the abdomen lightly in all four quadrants to determine the presence of tympany and dullness.
On palpation, keep your hand and forearm on a horizontal plane with fingers together and flat on the abdominal wall. Palpate with a light, gentle dipping motion as you move your hand. Raise it just off the skin, gliding smoothly, palpating all four quadrants. First is palpating lightly to detect abdominal tenderness, muscular resistance, and some superficial organs and masses. Next is to do deep palpation. It is usually done to identify the liver edge, kidneys, and abdominal masses.
To measure the vertical span of the liver dullness, using a light to moderate percussion strike, start in an area of tympany at a level below the umbilicus in the right lower quadrant, directly along the right midclavicular line. Percuss upward toward the liver. Identify the lower border of dullness in the midclavicular line.
In palpating the liver, place your left hand behind the patient, parallel to and supporting the 11th and 12th ribs. Tell the patient to relax on your hand. Press your left hand upward as you palpate with your right hand on the patient's right abdomen, lateral to the rectus muscle with your fingertips below the lower border of liver dullness.
The hooking technique. This technique may be useful in obese patients. The examiner stands to the right of the patient's chest. Place both hands side by side on the right abdomen below the border of liver dullness and press with your fingers and up to the costal margin. Ask the patient to take a deep breath. Liver edge is palpable with the finger pads. Next is on how to detect splenomegaly by percussing the spleen. There are two techniques. First is to percuss the left lower anterior chest wall from the border of the cardiac dullness at the 6th rib to the anterior axillary line and down to the costal margin, an area termed as the trob space.
Note the lateral extent of the tympani, which makes splenomegaly unlikely.
Second is to check for a splenic percussion sign. Percuss the lowest interspace in the left anterior axillary line, which is usually tympanitic. Ask the patient to take a deep breath and percuss again. For a normal spleen size, the area usually remains tympanitic. In palpating the spleen, with your left hand, reach over and around the patient to support and press forward the lower left rib cage. Ask the patient to take a deep breath. Repeat with the patient lying on the right side with the legs somewhat flexed at the hips and knees. Normally, no tenderness is present. In palpating the left kidney, move to the patient's left side. Place your right hand behind the patient, just below and parallel to the 12th rib. Lift the area with your fingertips just reaching the costovertebral angle. Place your left hand gently on the left upper quadrant, lateral and parallel to the rectus muscle. Ask the patient to take a deep breath. At the peak of inspiration, press your left hand deeply in the left upper quadrant. Ask the patient to breathe out and then stop breathing briefly, slowly releasing the pressure of your left hand, feeling the kidney to slide back into expiratory position. Usually, the left kidney is not palpable. In palpating the right kidney, return to the patient's right side and use your left hand to lift the back and your right hand over the right upper quadrant, lateral and parallel to the rectus muscle. Ask the patient to take a deep breath. At the peak of inspiration, press your right hand firmly and deeply into the right upper quadrant. Ask the patient to breathe out and then stop breathing briefly. Slowly release the pressure of your right hand, feeling for the kidney to slide back into its expiratory position. A normal right kidney may be palpable. If the kidneys are tender to palpation, a percussion tenderness test of the kidney is usually done to elicit a kidney punch sign, usually done by placing the ball of one hand in the costovertebral angle and strike it with the ulnar surface of your fist. Normally, no pain is felt. In adults over 50 years old, assess the width of the aorta by pressing deeply into the upper abdomen with one hand on each side of the aorta, slightly left to the midline to identify aortic pulsations. Normally, it is less than 3 centimeters wide.
Assessing possible appendicitis. Ask the patient to cough to see where pain occurs. Ask the patient to point to where the pain began and where it is now. The pain of appendicitis classically begins near the umbilicus, then migrates to the right lower quadrant. Another way to assess for possible appendicitis is to palpate carefully for an area of local tenderness. Classically, McBurney point lies 2 inches from the anterior superior spinous process of ilium on a line drawn from the process to the umbilicus. Assess the obturator sign. Flex the patient's right thigh at the hip with the knee bent. Rotate the leg internally at the hip. This maneuver stretches the internal obturator muscle. Right hypogastric pain is a positive obturator sign. Assess the psoas sign. Place your hand just above the patient's right knee and ask the patient to raise that thigh against your hand. Increased abdominal pain is a positive psoas sign, suggesting irritation of the psoas muscle by an inflamed appendix. Palpate for Robsing sign and referred rebound tenderness. Press deeply and evenly in the left lower quadrant. Then, quickly withdraw your fingers. Pain in the right lower quadrant during left-sided pressure is a positive Robsing sign. Murphy's sign. Hook the fingers of your right hand under the costal margin at the point where the lateral border of the rectus muscle intersects with the costal margin. Ask the patient to take a deep breath, which forces the liver and the gallbladder down towards the examining fingers. Watch the patient's breathing and note the degree of tenderness. A sharp increase in the tenderness with inspiratory effort is a positive Murphy sign. Test for a fluid wave. Ask the patient or an assistant to press the edges of both hands firmly down the midline of the abdomen. While you tap one flank sharply with your fingertips, feel on the opposite flank for an impulse transmitted through the fluid. An easily palpable impulse suggests ascites. Test for shifting dullness. Percuss for dullness in several directions with the patient supine. Map the border between tympani and dullness. Then ask the patient to roll onto one side, percuss, and mark the borders again. In a patient without ascites, the border between tympani and dullness usually stays relatively constant.